Yes, we are live now. Okay, over to you. I'm muting myself, and let's hope it goes smoothly, inshallah.
Thank you. Assalamu alaikum, everyone, and good evening. So this week is previous week was about the brain approaches. Dr. Kaval covered a lot of approaches with excellent way, and this week is spine week. So inshallah, we'll try our best to complete all the spine, most of the topics and approaches in this week. Dr. Mustafa, how are you?
Walaikum salam, sir. Thank you very much. Thank you very much.
Do you want to say something?
Yes, sir. All the lectures were wonderful, and we learned so much from. Bundle of thanks to your precious efforts, and to the respected also. Sir.
Thank you, and you people are always welcome. So let's start. Today's there is anatomy of cervical spine, and then we will go switch to the surgical approach, the anterior surgical approach to the cervical spine. Look at here, this is the whole spine from cervical to the sacral and coccyx. Okay, look at the curve of this one, and this is the beauty that how nature have given us this curve. Look at here. And this is actually, the spine is actually the transition from cervical to the lumbar one. It's a transition one. That's why the anatomy is being changed from cervical to the lumbar. Look at this, just how it is transitions. When we see from cervical, the body, there is no any body in first two, C1, C2. Then there is a body to the cervical spine from C3 to the C6. Then we'll come to this from T1 to T12. There is a bit change. The body is being enlarged, and the spinal canal is being short. When we come downward at the lumbar spine, the body is more large and more bigger as compared to thoracic one. Okay, why this is happening? Because it's it's very important to know the cervical has the C1, C2 don't have the body because it needs the movement. It's the more mobile part of the spine, that is the C1, C2 at the level of the occipito-atlantal and atlanto-occipital joints. If they will have the body, then there will be no movement at all, and the movement will be very restricted at that joint. That's why the nature didn't give us the body at the upper cervical spine. Okay, then they have body and small bodies, and because the cervical spine is the most mobile part of our the spine, that's why it has limited and small bodies, and a lot of ligaments actually are there because they control the movements. Then come to the thoracic, they have this body that is more bigger as compared to the cervical one. And then we will come to down to the lumbar part. The body is more larger and bigger, and elements are more larger. Why? Because it's the load bearing compartment of the spine, that is the lumbar area. That load is being transferred from the thoracic to the lumbar. It should have the large and bigger anatomy as compared to thorax. So this is the bit transitional points that nature has given to us. And one of that is the second is the curvature is very important. So look at the cervical, that it is the lordotic curvature, and that is the thoracic is the kyphotic. Again, the lumbar is the lordotic curve, has this one. That this is the normal anatomy, and it's very important. If anything is this transition is being disturbed, the whole spine will disturb. So this is the cervical spine. It has the 7 cervical vertebrae, C1 to C7. Look at the curvature. You can see that it is a lordotic, little bit curved. The C1 that has joined with the occipit with the help of atlanto-occipital joint. Then C1, C2, it is joined with the help of atlanto-axial joints. Okay. So we'll cover the anatomy in this way that the vertebral bodies of the cervical spine, it will be divided into two parts when it is the typical and atypical cervical vertebrae. Then we'll switch to the joints of the cervical spine. That is very important. After the joint, we will see the ligaments of the cervical spine, that what ligaments are there. After that, we will dissect the ligaments. We'll come above, from inner side to above. We are coming above. We will discuss the muscles of the cervical spine. Then we will switch to the surgical area. So let's start with the vertebral body anatomy. So we divide the cervical vertebral bodies into two main. One thing is the typical and second thing the atypical vertebral bodies. There are three atypical vertebral bodies. Anyone who want to share his knowledge regarding it? What are the typical vertebral bodies and why they are? Yes, Dr. Mustafa.
Sir, 1, 2, and 7, sir.
1, 2, and 7. Okay, very good. Thank you. Atlas, Axis, and the C7. These are the atypical vertebral bodies. Look at this one. The topmost on the left side is the C1. It has no any body at all. There is no any body at all. That's why it is the atypical cervical body. It has some specific and good features. Look at this one. It has two arches. One is the anterior arch. This is the anterior arch, and this is the posterior arch. Bilaterally, these are posterior arches. Anterior arch has the anterior tubercle. Posterior arch has the posterior tubercle. This is the anterior tubercle. This is the posterior tubercle. When we go laterally, look at here. This whole area is called the lateral mass. This is the lateral mass area, and this is the bit small transverse process of this one, in which there is a foramen that is called the transverse foramen is there, through which the vertebral artery comes out. It gives the vertebral out. Okay. So it has this lateral mass area. It has two surfaces. Look at here. This is the curved surface. That is the it is the joint which is attached above to the occiput. Okay, this is the posterior arch. So there is no cervical vertebral body in it. When we see internal structure of this one, it is quite a good one. So look at here. Again, it is very important because this area that is very important. It has some depression. Look at here. And this is the depression area because the hair odontoid, this is the odontoid. We call the dens of the C2, C2 dens attached here. C2 dens anterior part, you can say, look at here, C2 dens. C2 dens, this is the posterior part. Anterior to this one, the anterior part will attach here, okay, this area, okay, at this here. Because C2 dens has two parts. One is the anterior part that is attached to the inner surface of the cervical tubercle at the level of anterior cervical arch. It has the posterior surface as well that gives the attachment to the posterior articular facet, as well as it gives attachment to the transverse ligament. Later on, we will see that how transverse ligament is going, that we call also called transverse atlantal ligament. Actually, that is very important ligament. Okay, so this is actually the area where the transverse, the dens is attached. One. So when we talk about this C2, so look at it. It has one elongated part that is called the dens, also called the odontoid. Look at here. Dr. Rahul, please mute yourself.
Good.
Dr. Rahul, please mute yourself. Thank you. So when we talk about the C2, it has two components. One is the odontoid process of the dens, and again the rest of the C2 vertebrae. Okay, the dens, it has one important thing that it is give attachment to the inner side of the C1, and second, it gives attachment to the transverse atlantal ligament. Second thing that is important, the embryological point of view, when we see, actually they say that the dens, it is the remnant, or you can say the rudiment C1 vertebral body. Actually, it is the part of the C1 embryologically. That's why it is fused with the C1. We can see at the level of C1, but what happens later on, it will fuse with the C2. But actually, embryologically, it is the part of C1. That's why we have a good anatomical relationship of odontoid with the C1. When we see this one, it is quite same areas are there, but little bit elongated, and some you can say the different anatomy of C2. So look at here, this is the odontoid, and this is the articular. This again is the lateral mass area. That is the superior articular facet. Below to this one, this is the inferior articular facet. The transverse process of C2, they are little bit laterally and downward movement as compared to the C1. C1 is horizontally placed as compared to C2, but C2, that is a downward and medially going downward. And this is the transverse process, and this foramen, okay? And this is the lamina. You can see the laterally, this is the lamina, this is the pedicle of this one, this is the lateral mass, and this is the spinous process. The C1 has no any spinous process, but the C2, there is a little bit developed spinous process, and that is the bifid spinous process will be there. Okay, so when we move to the C7, actually, the C7 has the anatomy more or less likely from similar to that of the C3 to C6, but the different thing is there that it don't has the similar spinous process as compared to the C6, C3 to C6. One thing that about the spinous process of C7, that is the long elongated and more or less likely most of the time it is not bifid as compared to the C3 to C6. One thing. And second thing, the vertebral body, sorry, I am saying that the vertebral artery will not transverse through the C7, while the vertebral artery transfers through the C6 to C7, C6, C1. So this is the C7. It is the most similar compartments and parts of that is related to the other vertebral bodies: spinous process, lamina, and this is the pedicle. This you can see the pedicle, okay, and this is the lateral mass area. You can say, look at here, this is the superior articular facet. Below to this one, this will be the inferior articular facet, and this is the transverse foramen, and this is the body of the C7. Look at this groove. Actually, when we will see later on, we will combine and align this whole body, then we will see that how this groove is important. Okay, this groove, look at here, this one, this groove is the groove for the nerve, that is the nerve root. Later on, we will see that how nerve root rises from here. Okay. So when we talk about the typical vertebral bodies, it has some 6 parts of this one. One is the body, as the body is not present in the C1 and C2. So second is the vertebral foramen, that is though there in the C1, C2 there is there, but it is large and triangular as compared to the C1 and C2. But look at here, the C1, this central vertebral foramen is very large. Why it is so large? C2 is not so large, but yes. Yes, Dr. Mustafa, you want to say
Odontoid,
something?
sir.
No, why
Yes,
this
sir.
is so
To accommodate
large?
the odont.
One for the
To accommodate the odontoid.
odontoid, and second, so look at here, if we see actually, so this is the area that there will be the odontoid. Okay, anterior to this is the odontoid. But when you see again, this area is very large. It is a huge one. Look at here, this whole area. Why it's so large?
Sir, for the
Yes.
ligaments, transverse atlantal ligament, and
They're limited here at this place, not here. Yes, anyone else? Because of the spinal cord. Spinal cord is more bulky at the C1 because it's the level of, you can say the upper cervical is the level of actually the cervicovertebral junction. That's why the spinal is more bulky. When from C1T downward, L1, we will goes downward, the spinal is more bulky at the above level. It is more thin as in the lower level, most commonly in the thoracic. That's why when you see the thoracic spine, the spinal canal is small. The vertebral foramen is very small as compared to, you can say, the cervical. Because the cervical spine, the spinal cord is more bulky. That's why there's a huge foramen is there. So when we talk about the typical, that is the body that is small and oval as compared to C1, C2, it's supposed weight of the head. Vertebral foramen is large, triangular, contains a spinal cord. Transverse process is well developed in the typical one that contains the transverse foramen, transverse vertebral body, vertebral artery and vein. Spinous process is well developed and is bifid, that is splitted. Articular process is two. There are superior and inferior articular processes there, and we will see also there is a that is the zygo epiphyseal joints will be there, and last one there is a uncinate process up there that form the unconvertible vertebral joints. That is the vertebral joints of the Lashka is there. Okay, so these are six peculiar and specific characteristics of the typical vertebral bodies. Let's see. The typical vertebral bodies are from C3 to C6. So this is one of the typical vertebral body. You can see all the typical characteristics, that six characteristics are there. One by one we'll see. So look at here, this is the vertebral body. It is well developed. When we see this vertebral body, these two, look at here. This is called this one. These two are called uncinate process. This one, okay. It form a joint later on that is called the joint of foramen, the joint of Lishka. These are uncinate process. This is pedicle. This is the transverse process. It is well developed bilaterally and it has the transverse foramen. Lateral to the transverse foramen, it is a groove there. That groove is for the spinal root. Root is there, rise from here. Later on, we will see this is the superior articular facet, and below it is will be the inferior articular facet. Just go downward, and the posteriorly it is the lamina bilaterally, and that it is attached to the spinous process, and the spinous process is bifid. So it has all six characteristics. One is the body, uncinate process, transverse process, superior and inferior articular facet, lamina, and bifid spinous process. So that's why, and there is a triangular large canal is there. Look at here, it's a triangular large canal. That is all six typical characteristics that fulfill the criteria of typical vertebral body of cervical spine that are present from C3 to C6. Okay. So now when we talk about this one, let's see the ligaments of tear. There are a lot of ligaments that are important for this one. Most of the ligaments, they give strength and mobility to the cervical spine. One is the strip site, that is anteriorly placed. Look at here, this one, that is called the anterior longicular ligament. Mirror image of this one, when we see the posteriorly, that is the same kind of a ligament is there at the midline that we call the posterior longitudinal ligament. When we remove the spinous process and lamina bilaterally, we can see a thick strip is there. Can you see this one?
Yes, sir.
This one,
Yes, sir.
when we remove
Yes, sir.
this lamina, spinous process, inner side of this one, there is a thick band of this one. Look at here, this one, this is whitish. That is called the ligament flavum actually. This is ligament flavum, okay? This ligamentum flavum is there. So these are three important ligaments are there. Later on, we will see other ligaments that how that is are attached and oriented to all this one. This is another picture of this one. So look at here, the transverse cut has been done. There is a sagittal cut of this one. Sorry, not transverse, sagittal. Look at here, this is small thin area that is anterior to the cervical spine body, that is the anterior longitudinal ligament. Okay. And the posterior to the cervical body, there is a posterior longitudinal ligament. Okay. This is the lamina, this is the lamina, and this is the pedicle, and this is lamina. Okay. So look at here, this is the ligamentum flavum actually. This is ligamentum flavum that is attached at the posterior side, at the inner side of the lamina. So how the ligamentum flavum is arranged, it is very important. What happens actually, it is arranged in a manner that from one lamina to other lamina, at the level of lamina, it is spared. Okay, so you have to be careful about it. When we go posteriorly, this is the spinous process. You can say this one. This is spinous process. This is spinous process. Spinous process has two associated ligaments are there. In between these two spinous process, there are interspinous ligaments, and posterior to this one, that the ligament that posteriorly connect the posterior part of the spinous process from one spinous to another spinous process, that is called the supraspinal ligament. Okay, this is the supraspinal ligament that connects posteriorly from one spinous to another, and the ligament that is present in between the two spinous process, that is called the interspinous ligament. This is another picture that I took from the Greenberg. Most of the you people know very well that is the handbook of neurosurgery. That is a Greenberg. This is good picture of the ligaments, anterior and the posterior. So look at here. This is anterior longitudinal ligament. At the superior side, it has the membrane that is called the anterior atlanto-occipital membrane. Anterior atlanto-occipital membrane actually is the cephalad extension of the anterior longitudinal ligament from C2 to the clivus at the level of this one. So look at here, this is the anterior longitudinal ligament. At the C1 side, this is the anterior arch of the C1, and this is the odontoid, and this is C2. So at the level of anterior arch of the C1, it gives the another membrane or ligament that is called the atlanto-occipital membrane. Okay, so one other ligament of this one, when we see this one odontoid, this is odontoid and this is clivus. From here, it gives another origin of the ligament that is called the apical odontoid ligament that holds the odontoid in position and the vertical position actually. Okay, so just behind of this one, when we see at the level of craniovertebral junction from C2 to C1, we have the cruciate ligament actually. When we see at the transverse section, axial section, we will see the cruciate ligament. It gives a lot of part. Okay, lower part, that is the transverse ligament. This is transverse ligament, that is called the transverse ligament. Above, there is a cruciate ligament is there. When we go downward, there is another ligament is there. You can say that is the tectorial membrane. It is the posteriorly, just anterior to the posterior longitudinal ligament. You can see the tectorial membrane. Okay, it is two parts. One is the superficial part and the deep part is there. So these are the ligaments. When we see the posteriorly, there are two important ligaments. One is the ligamentum flavum. Look at here. This is the ligamentum flavum strip. And second is the posterior atlanto-occipital membrane is there. This is the level of C1 and C2. This is odontoid. This is C1 vertebrae actually, and it has the incorporated the C2 odontoid. Look at this odontoid. Odontoid bilaterally, it is anteriorly adjacent and attached with the alar ligament. Look at here, the right alar and the left alar. This is odontoid. This is anterior fossa at the posterior inner side, depression of the C1 tubercle and the arch where the odontoid attached. It has the joint is there. But the posterior, look at here, we have seen in the odontoid that it gives attachment to the transverse atlantal ligament. This is, look at here, this is the transverse atlantal ligament that goes posteriorly to the odontoid and keeps the odontoid in place, not retracted back to the spinal cord. Okay, just posterior to the you can say the transverse ligament, there is a tectorial membrane. Okay, this whole area is the lateral mass area. This is another picture that clears the cruciate ligament. Cruciate ligament has a lot of bands. Uh, there are two bands, that is ascending and descending band. That is, one ascending band is attached to the cheilitis, and this is the cruciate ligament whore. That is, look at it, this criss-cross area, ascending band and the descending band. Okay, this is the transverse band. That is actually is the transverse lateral ligament. This is a pietal ligament of the odontoid, and these two are the LR ligaments bilaterally. So these ligaments are very important to hold the atlantoaxial joints at its position and strengthen this one, because the mobility and the strength of the atlantoaxial joints and this upper cervical spine is because of these ligaments. And out of these two, the most important ligament are, which are most important ligaments?
Transverse
Yes,
lateral
please.
ligament.
Transverse lateral ligament is very important. Yes. Thank you. Thank you, Dr. Sana. Dr. Sana or Dr. Meher, who is there?
Sir. Dr.
Okay.
Meher.
So thank you. Thank you, Dr. Meher. So these are ligaments. Another one that is the part of this one that has the stability, that is the capsule joint ligament, the capsule joint, this one. It also considered some neurosurgeons and some academicians, they consider this one as the, you can say, the ligament, but actually it is a joint. This is the capsule joint is important. So let's start the joints of the cervical vertebrae. One joint that is formed between two vertebrae. So look at here. This is one vertebral body. This is another vertebral body. In between these two vertebral body, there is a disc, and this disc act as a joint. A fibrocartilage joint is this, and this is the end plate. This is the inferior end plate. This is the superior end plate of lower vertebral body, the inferior end plate of the superior vertebral body. And between these two, they have the fibrocartilage joint. With the help of this, they are joined with each other. So one joint is this one. This actually gives the position like, you can say, the shock absorber. You know very well that because of the weight, there shouldn't be displacement of this one. But when we see just posterior to this one, so this part, what is this part? Anybody?
Uncovertebral joint.
We have discussed in the anatomy. Uncovertebral joint. Excellent, Dr. Sana. So this is the uncus, uncinate process actually. This one, look at here. This is a superior uncinate process of the lower vertebral body, and this is uncinate process of the superior vertebral body. So that's why it is called the uncovertebral joint. That is called the joint of Lushka. So what is important of this joint? Importance of this joint? Yes, Dr. Sana, you gave the answer. You will tell. So
Sir, during dissection,
yes,
sir, during dissection, we have to stop to this point. Maybe I am wrong. During dissection.
What are you saying? Yes, please.
Sir, during dissection or
During dissection,
corpectomy, we have to stop.
So what we should, we should be stopped here.
Yes, sir.
Yes. Okay. Anything else? What is the physiological importance of this joint?
Sorry, sir, I don't know.
Anyone who can try? So look at here. Actually, the cervical spine is very, I told you that is a very mobile area that has the flexion, that is the extension, that is lateral extension, and the flexion, the rotatory movements. All movements are there in the cervical spine. So some joints, they will help in the flexion extension. But what about this uncovertebral joint that is called the joint of Lishka? It limits the lateral flexion. Can you see me? Look at here. The lateral bending. the lateral flexion. Okay, this limits the lateral flexion. Excessive lateral flexion will there will be damage to this one. Okay, this is the physiological importance of this one. What is the pathological importance of this one? Actually, what happens in the old age patients, these joints start to degenerate and becomes, there's osteophytes sometimes there. So the mobility, there is a restriction of mobility in this one. And sometimes when the osteophytes are there, the more degeneration is there, they can compress the nerve root is there. This is the point of nerve root. Look at here. Can you see this foramen?
Yes, sir.
This foramen? This actually the area of nerve root. Okay. When they become degenerative, or you can say the osteophytes is there at here, they can compress the area at the level of the nerve roots. The patient can have the symptoms of same radiculopathy. Okay, this is the importance of this one. So one joint at the intervertebral disc, fibrocartilage joint, that in between the two vertebral bodies. Second joint at the level of uncovertebral joint or the joint of Luschka at the uncinate process, that lateral limit of the flexion. Posterior, look at here, this one again. Yes, this one and this one. What are these areas? Which joint is this one?
So superior
And
articular facet.
this one. Excellent. This is the superior articular facet and inferior articular. The inferior articular facet of the superior vertebral body and superior articular facet of the inferior vertebral body, they have the joint over there. Okay, look at here, and these are the curves. The look at here, the superior one, it is curved. Look like this. Look at here. It is slippery. Why slippery? It helps in the flexion and extension. When the flexion is there, the flexion is like in the slippery movement is there. It comes anteriorly. When the extension is there, it goes behind. It goes posteriorly. So these are the three important joints of the vertebra of the cervical spine. Any question up to here? Any question? No?
No.
So look at here. This is a spinal cord. You can see this is the spinal cord. See the nerve roots. We have seen that when one vertebral body over there in the previous picture, it gives a foramen at the lateral side and here, and there is a spinal root is there. And this is the groove we have seen previously. And this groove is the groove for the spinal nerve. So look at here, this is the nerve that is coming from the spinal cord going downward in the spinal root. So this is the nerve, and these are the nerves over there. There are 7 cervical vertebrae, but there is 8 spinal cervical nerves. So this is and later on, you can see the good picture of this one. So what is this?
Brachial plexus.
This is brachial plexus. Downward, it has the brachial plexus from C5 to T1. It gives the brachial plexus. So these are the area that the how nerve root comes posteriorly. So this is area actually that is the joint of, yes, this is joint of
Uncovertebral.
uncovertebral joint. So look at here, this is the nerve root. When it becomes degenerative or when it becomes, you can say, the osteophytes are there, it can compress this nerve root and patient can present with the radiculopathy. Okay, so that's why these joints are very important. So we have completed the joints, we have completed the ligaments. Let's see the muscles. We divide the muscles of the anterior cervical spine into 3 major groups. One is the most superficial muscles, one is the intermediate, the lower muscles, deep, and the perivertebral and peritracheal facial muscles. So this is the superficial muscles of this one. After cutting incision, giving down to the skin. So this is large band is there. So which muscle is this one?
Platysma.
This is the platysma muscle, the large one. Okay, bilaterally. This one. This is the platysma muscle. Okay. So this is the most superficial muscle of this one. We will blindly dissect this platysma. Some surgeons actually incise it or try to blindly dissect this platysma muscle surgically when we go inside. When we dissect this platysma, we can see actually at the lower side, when we dissect this, we can see the lower belly of the, you can see the sternocleidomastoid muscles here. But above this one, the plasma muscle, we can palpate this sternocleidoid muscle. This is the sternocleidoid muscle is there. Look at here. Okay. And this will be our target when we are going to approach the ACDF. Okay. This will be our target, this area, anterior border of the sternocleidomastoid muscles. So the superficial most common when it is the plasma muscle, and second is the sternocleidomastoid muscles. Posteriorly, which muscle is this one?
Trapezius.
Trapezius, excellent. So this is another picture of this one. We have removed the plasma muscle and we can see the sternocleidomastoid muscle. This is the sternocleidomastoid muscle. Look at here. That is from lateral to medially, it comes downward. Okay, look at here, this one. Okay, when we remove this sternocleidomastoid muscles, we have two types of muscles actually. One is the anterior lateral muscles, that is called the pretracheal muscles, and second is the prevertebral muscles. Okay, when we will remove in a sense when we'll want to see the dissected anatomy of anterior cervical spine, we will remove the sternocleidomastoid muscle, we will see the two types of muscles. One is the pretracheal muscles and second is the prevertebral muscles. Look at here. This is the pretracheal muscles. You can see one by one, we will see that what are the pretracheal muscles are there. Okay. Look at here. These are the pretracheal muscles actually. Okay. There are four pretracheal muscles. This is hyoid bone, and this is thyroid cartilage, and here will be the sternum. Okay, this is hyoid bone, this thyroid cartilage, and the sternum. You have to memorize these three landmarks. Pretracheal muscles are named according to these three. Later on, we will see that how pretracheal muscles are arranged. There are omohyoid muscles. That's this is omohyoid muscles. You can see. Okay, this is the thyroid muscles. Look at here. This one, the piece posteriorly, and the sternohyoid muscles. One is the sternum to the hyoid, and one is the thyroid to the hyoid. That is called the thyrohyoid muscles, and sternohyoid muscles is there from sternum to the hyoid bone. So there are four pretracheal muscles. You can see this the transverse section that has been taken to this one. This is the area. This is what? Anyone who can interpret? Yes? No? Look at here. These are the muscles that are pretracheal muscles. These are the pretracheal muscles. 1, 2, 3 lateral. And this is sternocleidomastoid muscles. Look at here. This is sternocleidomastoid muscles. This one large. This is skin. This large muscle is, look at here. You can see this is plasma. We have cut it down the skin. We will see the plasma large muscle. Then laterally, we will see the sternocleidomastoid muscles. Anteriorly in midline, when we anteriorly approach, we have two types of the muscles there. One is the pretracheal muscles. I told you that these are the pretracheal muscles. This is thyroid gland. This is trachea. This is esophagus. Okay. When the anatomy is good, all things will be good for the neurosurgeon. Any type of the neurosurgeon. This is trachea, esophagus, thyroid gland, pretracheal muscles. Later on, we'll see what are these two. Yes, please, anyone.
Carotid
Yes.
artery, anterior jugular vein, vagus nerve.
Carotid sheath. Yes, you are right. Very right, Dr. Mustafa. This is carotid sheath. Okay. So that has the carotid artery, vein, jugular vein, and the what about third one?
Vagus nerve, sir. Vagus nerve.
Okay. Okay. And this is the pretracheal area. This is prevertebral area. Look at here. This is whole is the prevertebral area. Okay. So two types of the muscles, pretracheal muscles, prevertebral muscles. We have to be well aware of it. These are the posterior muscles. We are not going to this one, but we will address these muscles actually. When we see the prevertebral muscles is there, the anterior, our target is, this is the body of this one. Our target is this one. ACDF, in ACDF, our target is this area. Okay. This area we will target. The body, we will place the screw here, and this is the area where the nerve roots comes. These two muscles that is lateral part of the body placed. What are these two muscles? Yes.
Longissimus coli.
Longus coli, excellent. These are the two longus coli muscles. We will attack these longus coli. Just when we will go laterally, these are three muscles are there. Yes. Which muscles are there? Yes, Dr. Sana.
Sorry, sir.
These scalenus muscles are there. Scalenus muscles. There are three: scalenus anterior, scalenus middle, and the posterior. Okay. So our target is this one. So you should know these two muscles is important. These are the deep muscles. Actually, these are the deep muscles. So let's see. So look at here. This is the picture of prevertebral muscles, and these two deep muscles we can see very important. Now this one. This is the vertebral body. These are the vertebral bodies. Bilaterally at the side of vertebral bodies, this is the muscle that is called the. These are the longus coli. These are the longus coli. Okay. Just lateral to the longus coli, at the same level, there is the longus capitis muscles are there. Just most laterally to this one, that previously we have seen, these are three muscles are there: scalenus anterior, middle, and the posterior. But this is our not target in the anterior cervical approach. These two muscles are our target. We can encounter these two muscles. One is the longus capitis, and the longus coli muscles are there. This one. This picture you can see easily. This is the longus capitis muscles. This is scalenus anterior. This one same. This is longus coli muscles. These ones you can see in the midline bilaterally. These are longus coli muscles. So these are the prevertebral muscles. That is important. And this is the pretracheal muscles are there. These are the four pretracheal muscles are there. Look at here. This muscle is the omohyoid, hyoid bone. Omo means. Omo means. Yes, please. Why we call it omohyoid? Omo means shoulder area, shoulder. Okay, that's why it's called the omo. This is called the omohyoid muscles. And this is the muscle, that is the hyoid bone. This muscle is going downward till that area of sternum. That is called sternohyoid muscle. This one. Okay, this one. Okay. This, look at here. We have cut it down, this muscle. When we cut down, another muscle is there. That is the thyroid cartilage. This is the thyroid cartilage, and this is sternum. Name it. Yes, please.
Sternothyroid.
Sternothyroid. This is sternothyroid. This is the omohyoid. This is the sternohyoid. And one muscle is there. This is the thyroid cartilage, and this is the hyoid bone. And this is the muscle in between the hyoid bone and thyroid. That is called the thyroid muscle. Thyroid muscles. that is called the sternothoracic muscles, omohyoid muscles, sternohyoid muscles. So these are the four muscles that are actually, these are the peritracheal muscles. And the two important muscles were there, we have discussed previously, that is called the prevertebral muscles are there. That is the longus colli and longus capitis. So we have to be well aware of this one. So now we are coming to the approach of the cervical spine anterior. Any question up to here? Yes, please. Any question up to here?
No, sir.
No? Anything, everything is clear?
Yes.
Yes, sir. Yes.
Or no?
Yes, sir.
So this is the X-ray. Look at here. Of cervical spine. It is normal X-ray. Is it a normal X-ray?
Yes, sir.
Yes.
Or abnormal X-ray? These both are normal?
No.
No, sir. A slight loss of lordosis of the cervical spine on the right side.
Okay. So what do we call it?
Cervical spasm, sir.
Cervical
Straightening of
spasm. Yes. So look at here. Okay. I'm sorry that I have not touched the screen. So these. Okay. These are X-ray. We have to be well. Everyone is well aware of these are four lines. Yes. Yes or no? Yeah. Should I repeat?
Yes, sir.
These are four lines that. Yes, Dr. Mustafa, repeat these four lines.
Anterior vertebral line, posterior vertebral line, spinolaminar line, and the posterior spinous line.
Excellent. Anterior vertebral, posterior vertebral, spinolaminar, and posterior spinal line. So these are the four lines that actually tells us any abnormality is there, any misalignment is there, anterior posterior displacement is there. This is the area of canal. Look at here. This is area. It tells us that canal is normal or not, and any displacement of these posterior elements. These whole is called the posterior elements. Okay, so this is the basic of this one. So what in this MRI is there is problem? Is there any problem?
Yes, sir.
What problem is there?
Stenosis, sir. Stenosis.
There is a
Due to
stenosis. Is there any central stenosis or the foraminal stenosis?
sir, due to the cervical disc herniation, sir.
Yes, there is a stenosis, and there is so significant stenosis there that it has the cord signals. The patient has the cord signals associated. The stenosis is so severe is there. Okay, so actually, just I want to tell you the indication of anterior cervical approach. Indication of cervical approach is mostly when is the pathology is anterior to the spinal cord. When the pathology is anterior to the spinal cord, we can approach the anterior cervical approach. Not only the ACDF is there. ACDF is one approach of the anterior cervical area for the discectomy. But when the pathology is anterior, we can go for the anterior. When we say the degenerative cervical spine, when the pathology is limited to the 1 level to 3 levels, we can go anteriorly. When there is OPLL, we can go most of the time anteriorly. There is also the posterior approaches are there. When the one important emerging approach is there anteriorly in the OPLL, we will discuss if we have the time. Otherwise, we'll switch to the tomorrow. When we have the fracture is there, trauma, we can approach anteriorly. The single level we can fix if there is any locked facets are there, the posterior elements are not disturbed, then we can go anteriorly. Okay, what are the locked facets? So these are some of the indications of anterior approach. What are the locked facets? Look at here. So there is a subluxation. Okay, 2, 3, 4, 5, 6, 7. Cervical C6, 7 is the subluxation is there. So what is the mechanism of injury in this patient?
Axial loading and hyperflexion, sir.
Axial loading and hyperflexion. Why hyperflexion?
It seems,
Yes, you are right.
sorry.
It's
Because
not
the,
hyperextension.
because, yes, sir. Hello.
Look at here. It is extended. Spine is extended, not flexed. Then why hyperflexion?
Sorry, sir. Hyperextended. It seems like hyperextension, sir.
Hyperextension.
Yes, sir.
Why hyperextension, Dr. Mustafa?
Because, sir, there is still lordosis of the cervical spine, sir.
So how you think that it is a hyperextension? Because it's lordosis.
I am 50-50 like
Remember one thing, there are two important things to see the mechanism of cervical spine injury. When the patient comes to us and we took the imaging, like the X-ray, like the MRI or the CT scan, actually it is not the X-ray of the time of injury. Okay, it is the post-traumatic X-ray or the post-traumatic CT scan or post-traumatic MRI. So in the post-traumatic MRI, actually what happens when we see the MRI, CT scan or X-ray, this is the hyperflexion injury. First time you were right. This is the hyperflexion injury. Look at here. The C7 have going back. What happened when hyperflexion was there? There is a tear of this one. It gives the force to the anterior end plate of the C7. It breaks down, disrupted, and it goes back. Then what happens? The post-traumatically, spine little bit extended in the hyperflexion injury. That's why it is very important. When you will see the imaging post-traumatically, you will see then a hyperflexion. The lordotic curve will be intact little bit. Patient looks that it is a hyperextended, but actually this is the hyperflexion injury. Why? Because the vertebra, the lower vertebra has go downward. When it comes anteriorly, the above is posterior, the lower one is anterior, then it is the hyperextension injury. Okay?
yes, sir.
Okay?
Yes, sir.
So remember one thing, right in the span that it is the hyperflexion injury, the mechanism of hyperflexion. When there is a locked facets there, we can switch to the 360 approaches there when the multiple anterior and the posterior, because posteriorly we have to unlock the facets. Okay, but when there is unlocked facets are there, we can go anteriorly in the post-traumatic area, post-traumatic picture. So what are the steps of anterior cervical discectomy? Actually, I say there's 7 steps of anterior cervical discectomy is there. We will start from the patient positioning. There should be the supine position, legs slightly extended, away from little bit to the surgical area. Skin incision, it's up to you when there is a single level. The transverse incision along the crease of the, you can say the neck, or you can see the vertical incision we can give when we have the multiple levels, more than 2 or 3 levels we can give at the anterior border of the sternocleidomastoid mastoid muscles. Then we have to give the exposure. Exposure, what exposure? That first we have to divide the plasma blindly and bluntly. Okay, dissect the plasma muscles and the sternocleidomastoid muscles. We have to seat the carotid sheath and tracheoesophagus. When we will dissect the plasma, we will appreciate the anterior border of the sternocleidomastoid muscles. What happened? We will see 2 things. One is the carotid sheath laterally. Medially, we will see the trachea and esophagus. Medially, we have to retract the trachea and esophagus. Laterally, we have to require the carotid sheath associated with the sternocleidomastoid muscles. After that, we have to see the exposure of the cervical vertebrae. We have to appreciate and address the prevertebral fascia. Then we will open it. Then we will see the longus colli muscle, Then we will retract the longus colli muscles laterally, bilaterally. After appreciating this and retracting back laterally to the longus colli muscles, we have to see and localize the disc level with the help of spinal needle, the one needle, any kind of needle. Then with the help of C-arm, we will see the level, and if there is a level is confirmed, that we will dissect the disc. Annulus fibrous will be incised, nucleus pulposus will be removed, and any kind of herniated disc that is causing the compression will be. Then we have to confirm it. How we have to confirm it? That as I've seen, we have to confirm with the help of posterior longitudinal ligament. If the posterior longitudinal ligament is relaxed, there's no any compression over the posterior longitudinal ligament, then we will see it. Most of the time we don't open it, the posterior longitudinal ligament. Sometimes we can open it if we see that it is not decompressed. Then we will see the spinal cord and nerve roots being depressed or decompressed or not. After that, we will, for fusion person, we will put the graft or cage. You can put the same the graft of the patient, that is the anterior superior iliac spine. We take the graft from their bone graft, and we can see put the cage inside it, or you can say the artificial disc you can put there. Okay, then we have to place the plate and the screw that is applied. So these are actually the 7 steps of the surgery in the anterior cervical discectomy and fusion. Okay. So what are the should be the landmarks of ACDF? This picture shows very well. We start from the C3 to C4, actually the most level. This is the angle of mandible. At the level of angle of mandible, there will be the level of C1, C2. That is not shown here. But this is the level of C3, 4. This is the hyoid bone. This one is the hyoid bone. That is the level of C34. The C34 level, there will be the level of hyoid bone will be there. So we can give incision at the level of hair, at the level of hyoid bone when we are approaching C34. When we are approaching C4, 5, we should know the thyroid cartilage level. We can give the incision at the level of thyroid cartilage. Just below or downward, there will be the crico thyroid membrane will be there. Okay, at the level of C5, 6, cricothyroid membrane will be there. We can give incision of the level of C5, 6, or you can say just the first tracheal ring. At the level of first tracheal ring is there. When the first tracheal ring is there, lower to this one, there will be the first incision of the C5, 6. At C6 level, there are 2 levels are there. One is the carotid tubercle and the carotid ring. We can give the incision at the mark at the level of C6, 7, C6, and the C6 level just below to this one. We have to see the at the level of carotid tubercle below to this one. So these are some landmarks of cervical spine. This is sternocleidomastoid muscle, this one, and this is the anterior body of this one. The incision will be little bit oblique like this one. When it's up to us that what approach are there. If you are going to the C5 to 6, below to C5 to 6, most of the time we approach the left side, but most it's up to the surgeon that what side you choose. The right side is the standard side. The most surgeons stand on the right side area. So this is the position of the patient. There should be the supine position. The shoulders should be retracted downward. The little bit extension should be there, and the little bit contralateral position should be there while standing at the surgeon side. Okay, so this is the skin incision over there. Okay, this is sternocleidomastoid muscles. Between the trachea and the sternocleidomastoid, we will feel, you can feel the trachea and you can feel the sternocleidomastoid muscles. In between that one, you can feel a depression is there, and that will be our targeted area. It's up to you that multiple levels, the longitudinal incision and single level, we can give the transverse incision is there. After that, it's very easy in the steps we have discussed. Skin incision superficial. After that, there we can see this is the superficial muscle, that is the plasma. After plasma, this is the sternocleidomastoid muscles. We have to retract it laterally. sternocleidomastoid muscles, and this is the medial part of this one. We have to see the medial part of this one. This is the area of trachea, or you can say associated with the esophagus. We have to retract it medially, but very gently. While we are retracting it, the trachea and the esophagus medially, we have to say the anesthetist that please deflate the ETT tube, because sometimes it has got the injury to the trachea. So when we will retract it, we will see that deflate it. After that, we can again say that inflate the trachea. Okay, be careful about it. After that, when we're reaching downward, we have see the pretracheal muscles. In pretracheal muscle, one muscle is very important, that is called the omohyoid. We have to retract the omohyoid medially, and we shouldn't dissect it. We shouldn't cut down the omohyoid. Okay, we have to retract medially. Then we will, after retracting it, we will see the downward. There are two muscles are there laterally. You can see this one and this one. That is called the longus colli muscles. After the longus colli muscle retracted laterally, how much longus colli should be retracted laterally?
So less than 1 centimeter.
Is too much. It's too much. 1 centimeter is too much, I think. Yes, less than 1. You said less than 1 centimeter?
Yes, sir.
Yes, you're right. Okay, sorry. So less than 1 centimeter. Why not more than 1 centimeter?
Sir, sympathetic.
Sympathetic. Okay, good. Sympathetic channel will be disturbed. Okay. They are saying that up to 2 mm to most important that not more than 2 mm. The ideal is the 2 mm, but maximum is 2 to 10 mm retract back downward. When we retract downward, you have to identify the disc level. When we identified it with the help of needle, it is the same one. Then we will discectomy will be performed first till that the posterior longitudinal ligament. But when we are approaching at the level of discectomy, we have done the discectomy. Ideally, the discectomy should be done with the help of naked eyes, or you can say the microscope.
The microscope,
And
ideally.
when you are giving the exam, you say that ideally I will use the microscope. Okay, with the help of microscope, or discectomy done with the help of microscope, we will see the posterior longitudinal ligament, that it is the decompressed, or still there is a compression over there. If it is not compressed, posterior osteophytes will be removed. We can open the posterior longitudinal ligament, and then we can see the nerve is there. It is decompressed or not. If there is, then we can. There are two options again. We can repair the posterior longitudinal ligament, or if there's a 1 centimeter, less than 1 centimeter, you can leave that one. Okay. Then we have to, according to this one, is a single level. We can put that plate. First, we have to put the graft. It's up to us. That is the bone graft or cartilaginous one, or the, you can see the artificial graft is there. What we are putting, then we have to put the plate in front of that one. That is must. Okay. Then we have to close it. This is another picture. The exact picture we are doing at the level of C5, 6. This is the platysma muscle. Skin has been cut. This area is platysma muscle. This is sternocleidomastoid muscles. Look at this here. Okay, this here. This is actually the carotid sheet, and most medially there will be the omohyoid muscles. Okay, this is the carotid sheet. We have to retract this one laterally. Oh, sorry, this is the sternocleidomastoid with carotid sheet, and this is the area of medially. There will be the esophagus and the trachea, and here will be the most medial part will the omohyoid. We have to retract this sternocleidomastoid muscle and carotid sheath laterally. We have to retract this one medially. Okay, when we see this one, when we retracted this one, we will reach up to the level of a prevertebral area. This is the prevertebral area. You can see. And these are the longus colli muscles bilaterally. Okay, this is the longus colli muscles. Okay, we have to retract this longus colli muscles laterally. Then we'll appreciate this is the disc level. Okay, we have to remove this fascia with the help of pen field. First, we will, with the help of diathermy, we will remove it. We'll literally retract it. Then we'll discectomy will be done and performed.
Dr. Itzaz, we are running out of time. It's been more than 1 hour. I know exactly why you're laughing, but we have run out of time.
Yes, I know that why you are saying so. So we have done it. Discectomy has been done, but the important in this whole, there are two important things are there in the exam point of view. What examiner expect from the candidate actually? One thing, he or she should know what instruments he or she is using, what kind of plates are there, what kind of gadgets are there, materials are using. First thing. Second thing, how steps, what kind of is how there is, what are the steps of the surgery, and what gadgets microscope are using or not. And third, what complications could be there and how he or she can encounter that compression and deal that compression. These are the materials that are using. One is the plate. So how many types of the plates are there? These are the anterior cervical plates. Can you see this one? And what is this one? You have plates this one.
So zero
Anyone?
profile.
Yes, yes. What you are saying, Dr. Sana?
So zero profile cage.
Very good, excellent. This is zero profile cage. Why we call it zero profile cage, and what is the importance of this one?
Sir, because it is kept inside the vertebral body, it has screws inside it that does not comes out of it. Yes, sir.
Excellent. There is no need to place the extra plate over there. It has 2 screws. Most likely it has 2 screws, and sometimes it has the 4 screws, 2 above, 2 downward. But 2 in the above superior vertebral body, 2 in the down superior body. We will close these screws. There it is inside this one, and it has the graft there. This graft is actually works as the disk, okay, inside this one, and it don't comes outside. Why we will use it? Why we call it zero profile?
Sir, no
What is
reaction.
important? Then
No, sir.
actually the advantage of this one, these as there is no in front of this one, no plate, actually there is a less chances or no chances of dysphagia or odynophagia. That's why we call it the zero profile. Okay, one is the low profile as well. That is little bit we can see anteriorly, and one is the zero profile. Low profile and zero profile screws, and the materials are used when there is we say that in these one there is no any dysphagia or odynophagia will be there in these patients. So because when we will place this plate, this is the zero profile, and there is no chance of most likely dysphagia in this one. When we talk about the plates, actually the anterior cervical plates, these are placed anterior due to this level, this hair. Okay, and there is chances of dysphagia in these kind of patients because the plates are there, so patient can feel the dysphagia. Okay, when we talk about the plates are mostly the 2 types of the plates. One is the static plate, that is called the rigid plates, and second is the dynamic plate or flexible plates. Okay, dynamic plates and flexible plates. Rigid plates are those plates, they are immobile, that are rigid. Screws and plates, they are fixed. Like we use rigid plates in the portions of the trauma when we need more stability, less movement when restricted there. So most of the time, rigid plates are used in the patients of the trauma. And the flexible plates are those in which there is a flexibility and the movement between the plates, and the screws are there. There are dynamic plates are there. Any direction that screws can be moved. That is called the dynamics. Dynamic plates, most likely these are used in the patients of degenerative cervical spine, or when you need the mobility preserved. That's why. The drawback of the rigid plates is that when we will decrease the movement of cervical spine, later on what happens, one chance is that they give pressure to the adjacent disc and the patient came with the disc herniation to the adjacent level. So these are the drawback of the static plates. But the flexible plates, they are very good. Again, the flexible plates have different types, the transitional, hybrid, and these ones. But we should know the four important ones. Static plates or rigid plates, flexible dynamic plates, two types, the transitional hybrid, zero profile and the low profile. Okay. So thank you so much. I will not talk about the, you can say the complications. It's very important, but tomorrow where we will discuss, when we purely discuss some surgical approaches, we'll discuss the complications. This ACDF has been done, carpectomy, ACCF is there, carpectomy is there. We will remove the vertebral body, we will place the cage and we will place the plate. This same will be the ACCF instead of the ACDF. Okay, up to here, any question? Thank you so much. Up to here, any question?
Yes, sir. Please. Sir, what can be the size of plate? Is there any rule for deciding the size of plate or cage? Or, sir, we can use.
No, actually, it depends upon the level of the cervical spine. That how much level is there. Okay, it's a single level. It is the you can say the 2 levels. It's the 3 levels up to 4 levels, and depends upon the size of this one. And that depends on the size of this one. You can choose this one. If the single level is there, then the length will be the most likely to the 22 to 23. Okay, the 22 the length you can choose, the minimum length that is. Okay, but it's the more level are there. According to level, you will categorize that what kind of plates you are going to use. But single level 22, 24, more than that one you can use the 26, 28. So it's up to you, and it depends on the level of this one, single or multiple levels. Yes, we have to choose the size of this one. It is mentioned here, and tomorrow I will give you all the details of the plates, that what kind of a size is there. Okay, so it depends on the level.
Yes, sir. Thank you.
Thank you, sir.
Anyone else? Any question? So thank you so much, and thank you everyone, and thank you Dr. Kamal for being there. So
Thank you, sir.
It's okay. We can continue the posterior approaches tomorrow. I'm so sorry for laughing, but that's okay. We can continue them tomorrow.
no, still there are anterior approaches are there. There are still anterior approaches are there. So we have to
that's
cover
okay.
it.
That's okay. We can do that tomorrow.
So inshallah, tomorrow we'll cover. Anterior cervical displacement approach we will discuss. That is very important. That is the emerging approach for the OPLL, that how it is being used nowadays. So we'll discuss that one, and then we will switch to the posterior approach. Thank you so much.
Thank you so much, everyone. Thank you for joining. Thank you, Dr. Chaz, for taking out so much time. We are going to bother you tomorrow as well. That's a wrap for today's session. Thank you so much, everyone.